Hi, I'm Larry Micarenda, and welcome to Excelsior Forum. And with me today is Vedant Vaksha. He is a spinal surgeon, and we have heard that terminology, oh my aching back, and hopefully he's going to tell us a little bit about what's going on with that aching back. If you would just tell the audience a little bit about your background and how you got to become a spinal surgeon.
Hi, I'm an orthopedic surgeon and I did fellowships in spine surgery. I did two fellowships, Rochester, New York and Cleveland Clinic, Ohio. And spine has always been my passion. So with the background of fellowships, I have been practicing spine for the last few years now, taking care of patients surgically, non-surgically, of their back, of their neck and the lower back.
Now, how exactly is the back put together? I mean, we always hear disc and hernias and all these other things, and we'll get into those later. But how is the back basically put together?
So back is made up of vertebrae, which are multiple bones stacked over each other. Now, there are 7 vertebrae which make up the cervical spine or the neck. There are 12 vertebrae which make up the thoracic spine or the upper back. And there are 5 lumbar spine vertebrae or the lower back. Then there are 5 sacral vertebrae, which are all fused together to make one bone called sacrum. And there are 3 to 5 coccygeal segments which fuse to become a coccyx. So essentially, there are 3 segments of the spine: the neck or the cervical spine, the upper back or the thoracic spine, and the lower back, which is lumbar, sacrum, and coccyx. These are all stacked over each other to give a structure which holds the body together, helps in transmitting the weight of the upper body onto the lower body and the legs. At the same time, they protect all the nerves within the spinal canal which go down the body to supply the muscles as well as bring the sensations back onto the brain.
Now, that was a mouthful, but the disc, we hear a lot of times slip disc and everything. Where exactly are the discs in the back? Are they between the bones?
Between each of these segments are mobile onto each other. So there has to be something between the vertebrae to help them with the mobility. Essentially, every vertebrae is with each other makes 3 joints. 2 are the facet joints, which are on the back, and the one is the intervertebral joint, which is essentially the disc. So the disc is a cartilaginous structure between 2 vertebral segments. It is made up of a fibrocartilaginous outer ring and gelatinous inside, which is called the nucleus pulposus. This disc is hydrated when we are born, and it gradually, as the aging process, loses some of this hydration, loses its water content, and that's what happens when we call degenerative disc.
Now, you hear slip disc a lot. I slip a disc in my back. How does that occur? What's happening with the body when you slip a disc?
So essentially, when we talk about slip disc, what it means is that there possibly is an annular tear in the disc, or some of the material from the inside, what we call the nucleus pulposus, comes out from the disc, pushes behind the disc, and maybe compress one of the nerve roots. This is essentially what is slip disc, and this is closely related to what is called the degenerative disc disease, because with loss of hydration, as we discussed, the disc is prone to injury, prone to tears, and this gelatinous structure comes out pushing the nerves.
So if you have a slip disc, even if you fix it, it's a good chance that you could re-injure it very easily? Or?
Yes, as the disc is already in an aging process. So the injury that has happened caused the slip disc or the disc herniation can again happen. Can happen on the other side, can happen on the same side. But it is unusual, though not impossible, to have the same thing at the same level on the same side.
Now, we talk also about we have pinched nerves or sciatica. So let's take pinched nerves first. What happens with pinched nerves? Is the disc is eroded and the nerve gets in there? I really don't know.
Yeah. So as you know, the nerves are present in the spinal canal, which is protected by the vertebrae itself. The nerves at each level get out of the spinal canal from every vertebrae. Now, this is the place where the nerve root is surrounded by multiple structures, which is facet joint on the back, bones on the sides and front, but also a disc in the front. Now, this disc, if herniated, can push this nerve root and decrease the space for the nerve root. When the space for the nerve root decreases, it gets irritated. Its blood supply gets decreased, it gets inflamed, and that's when it becomes painful. It presents with pain in the area that's going to supply, and it may be associated with other symptoms like tingling, numbness, rarely weakness. There are nerve roots which supply the bowel and bladder function. If those are involved, then they may involve the bowel and bladder function, and patient may have retention or incontinence.
So you can actually, from having something wrong with your back, it can actually affect your internal organs also.
Yes, essentially the internal organs that usually get affected if there is a problem in the back and nerves getting compressed are bowel and bladder. The other internal organs of like in the belly and all, they are essentially supplied by the other nerves which are not contributory from the back.
Right. So that whole lower back area that you would call the lumbars.
Lumbosacral spine.
Right. I'm sorry if I can't pronounce all these words. But also, we talk about sciatica. We hear that word so much in so many back injuries. What exactly is sciatica?
So sciatica word comes from the inflammation or pain along the sciatic nerve. The sciatic nerve is formed by multiple nerve roots that come out of the spine and fuse to become a thick nerve called the sciatic nerve. This nerve travels from the back of the hip into the back of the thigh, into the back of the knee, divides there, making it small branches and supplies all the way along. When the nerve roots of usually L5 and S1 are compressed, because these are the most mobile segments of the lumbar spine, patient starts having pain which goes along the back of the thigh and the leg or on the outer aspect of the thigh and the leg. And this pain which goes from the back towards the toes is essentially described as sciatica.
Now, also, can that sciatic nerve give you pain in your hip?
Yes, very good question. So the sciatic nerve can occasionally present with pain in the hip. Now, it's not usually because of the nerve itself, but because of the pathology that is causing the sciatica, because it is compressing the sciatic nerve at the same time. There is some pathology going on which may present with the hip pain also.
Now, the way to diagnostic, all right, there's so many areas of the spine, the neck, like you were saying. How do you go about diagnosing some of these diseases?
So first of all, as a clinician, a history and physical examination is of paramount importance for these patients. The physician, by the history itself, supported by the examination, can make a clinical diagnosis as to what's going on. But then we need relevant investigations to support our diagnosis, especially when we are trying to do something actively for the patient to relieve the patient of the pain. So we do x-rays, and just to see if there is no fracture, no subluxation, dislocation, as to the amount of arthritis that's going on or any other relevant finding. Then, if needed, we do advanced imaging like the MRI. MRI helps very much in delineating all the soft tissue in the spine. It gives us how the disc is, how the capsules, how the facet joint, if there is any cyst, fluid-filled cyst, if there is any ligament which is buckling, causing compression of the nerve roots. There's a lot of information that we get from the MRI.
Now, do they ever use like sonograms for the back or anything like that? Or no?
Sonogram is not usually used for the back, but we can still use investigations like CAT scan. We can use investigations like putting dye into the spinal canal and taking a CAT scan after that, called the CT myelogram. And this is essentially done in patients who cannot undergo MRI. And this is a population who have MRI non-compatible pacemakers usually, some patients with aneurysmal clips or certain implants which cannot undergo an MRI. They are helped by a CT myelogram.
Now, we've mentioned and spoke before about osteoporosis on this program. And one of the things is that these back injuries are not just limited to people who are over 50 or over 45. You also deal a lot with athletes and sports medicine because I guess through the rigorous bending and jumping and everything else that they do. How do you go about treating patients who are younger who are starting to have these spinal problems, because they may lead to much worse problems later on in life?
Yes, younger population is prone to spine problems. more often like disc herniation rather than the older population who are more prone to conditions like spinal stenosis. Now, younger patients are a tricky population because we don't want to do too much because they have a lot of life in front, but at the same time, we don't want to leave them in pain, which will make their life very difficult to go on. Spine surgery, as almost any other orthopedic surgery or today's medicine, is more about quality of life. So we try to do optimum so that they can regain their quality of life and live better.
And a lot of times, and I know from the other doctors we've had on the program, they don't want to be pill doctors. They don't want to keep filling people with painkillers and stuff like that. Of course, you know, there are some cases that may be different, but the majority is to treat and to, you know, get rid of this problem, not to just keep throwing drugs and stuff like that at. So you also are specialized in certain therapies also for the back, right?
As a surgeon, I do prefer that I keep the patient off especially the narcotic medications. When I need to give them, I will give them, but I try to keep them off that. So I try to do therapies or surgeries so that they get better of all the problems that they are having and they get off the medication as soon as possible for them.
Now, we were talking about athletes before. Spondylitis, I believe it is, and the spinal stenosis, what are they?
So spondylitis is another technical term for degenerative disc disease. And this actually starts early in the age, 30 or 40 years age, but usually it's asymptomatic and patients do not present till the age of 50, 60, depending on their symptoms. Now, in patients who are athletes, who are sportsmen, they may have had rough injuries in their back in the past, which can accelerate the process of spondylitis, and they may present early. And these are the patients who may present with disc degeneration, disc herniation, and they may need treatment for that. Contrary to that, older population presents with more of spinal stenosis. In this, they may have disc herniations, but they may also have buckling or calcification of the ligament, which is on the back of the spinal canal, called the ligamentum flavum, and multiple disc bulges, and they usually present at multiple levels. These are the patients who, contrary to the disc herniation patient who present with the radicular pain or the sciatica, these will present with pain or nagging sensation in both their calves, both their legs after walking a certain distance. And they will tell you, right, I walk a block and then I cannot walk. I want to sit down, I need to bend forwards. These patients, when they go to a grocery store, they will take a grocery cart and lean on it, and then they can do shopping. If they don't have a grocery cart, they won't be able to shop because they are not able to lean. So these are the patients who are spinal stenosis.
Now, we hear the term subluxation is used a lot. Now, subluxation sounds like some sort of building block or something like that. Can you tell us really what that is?
Yes, so subluxation is what it means is partial dislocation. That means that bodies, the vertebral bodies, are in contact with each other, but they have separated slightly or slightly more, but not completely. In spine, the word which we use is spondylolisthesis for the same thing. That means that the patient has a movement of a upper body over the lower body. And these spondylolistheses are divided into grades, grade 1, 2, 3, 4, and even 5, depending on how far it has gone. Most of the patients, and these patients are usually of a degenerative disc disease, present with a grade 1 spondylolisthesis. Mm-hmm. And these patients, again, do not need treatment till they have symptoms, which may be just back pain or which may be a radicular pain going down their legs. They may also have tingling, numbness, weakness, gait problems, walking problems because of the weakness in their muscles. Very rarely they will have a bowel or bladder problems.
Now, sometimes people think it's restless leg syndrome when it can actually be the back and the, I believe you said the lumbar part of the spine, because the spine's broken up into 3 sections, right?
Yes.
Now, we also hear the word spinal tap a lot, which is scary just to hear the word of it. But basically, what is that procedure? The spine fills up with fluid, it has to be drained, or?
Spinal tap essentially is a procedure in which we put a needle into the spinal canal to pull the fluid out. And this is more often a diagnostic procedure in which this fluid is taken out and sent for the lab for some testing. And these are done if we are suspecting a patient to have some brain infection or some spinal cord problems, which may be causing inflammation and all.
So when is it the time to see a doctor? When you are having, these problems with the back, I mean, should you just say, "Oh, I'm going to take a pill or ibuprofen or something like that, and I'll be okay in a day or two"? When is the time to come and see you or see a doctor?
The 80% of human population will suffer back pain once in their life. That does not mean that all 80% have to see a doctor. Most of these back pain are self-controlled, self-restraining. So just treating them with a short period of rest, taking some medications over the counter, using some ice, maybe heat, it can help alleviate the pain, and that's it. But if the pain is not getting better with all these modalities in 3 to 5 days, then they should try to see their primary care to know as to what's going on. And they may actually start some physical therapy for them or educate them how to use their back more efficiently. But there are times when you start, especially when you start having pain going down your legs, which again does not get relief with the usual medication, then you may have to see a spine surgeon, a pain physician, someone who specializes in taking care of back pain which is associated with radiculopathy or sciatica. And this is the time when you see us.
Now, also the term has been used, spinal fusion. Now, that's something that sounds scary too, but basically, can you tell us a little bit about what that is in case maybe somebody's out there who's going to have this procedure done?
Yes, so most of the times the procedure that we try to do is, like for pain, we are doing a procedure is decreasing the pressure from the spinal roots, and this can be done in the form of discectomy or laminectomies. Occasionally, patient may have what we discuss about like subluxation or instability of the spine. These patients, if they just undergo a laminectomy or discectomy, will further aggravate their instability and have problems. So these patients usually need to undergo a fusion surgeries. Also, if patients have more of back pain than the leg pain, then fusion surgery is a better surgery for them to take care of everything which has been going on and alleviate all the symptoms.
Now, could some of these spinal problems also cause like twitching in the legs, pain that constantly comes and goes, recurrent pain? Some of the other things are like total numbness. I know some people like the pain's in their back, but they can't feel anything in the bottom of their feet. Is that all because of the sciatic nerve, or is there something else going on?
Yes, so there are certain patients who may have really severe form of this disease, and people need to understand when there is an urgency to go to see maybe a doctor, maybe urgent care, maybe emergency room. These are the patients who start developing worsening, tingling, numbness, pain, weakness of muscles. They start slapping their foot on the ground when they are walking, which is called a foot drop. Patients may have numbness around their genitalia. Patient may lose control of their bowel, bladder, and these are emergency conditions. They should seek urgent care so as the process which is causing this may be diagnosed and stopped as soon as possible. The diagnosis word that we use for here is a Cauda-Equina syndrome, which is an emergent diagnosis and usually need surgical treatment to take care of it.
Now, you had just mentioned before about a discectomy, and I think it's a lumbarectomy, if I'm pronouncing
laminectomy, yes.
If I'm pronouncing it.
Yes.
What are those two procedures?
So these procedures are done in patients who have compression of their nerve roots because of a disc herniation. Then what we do is we go inside through small incision, minimal invasive surgeries. We use microscopes, we use tubes, we use visual enhancers, and we go in, clean a little amount of bone, go onto the disc, remove the disc which is causing the pressure on the nerve root. The results are great. These patients do really well. This is a very small surgery, minimal invasive surgery, and this surgery do not contribute to the instability of the spine for the future, and patient gets relieved. Laminectomies are usually done if the patients have symptoms on both sides, or in patients who we discuss as spinal stenosis, because there is more of stenosis in the center. There's a thickened ligamentum which we talked about, maybe calcified. We need to remove that, and then laminectomy is done. Again, a very successful surgery, very good results.
Now, with the way surgery has gone, now you've been around for a while, and how would you say that the way modern medicine, just during the past 6 years in your field, has changed. It's pretty incredible, isn't it?
Yes, the best things that we have got are visual enhancers, the optics, the microscopes, the loops that we use, the lights that we get, apart from instrumentation. Also, we have developed very new surgical techniques over the last, I would say, 10 years, 15 years. And these surgical techniques and enhanced implant material have especially helped us in developing the fusion surgeries. Initially, fusion surgery was only done from the back. Now we can do the fusion surgeries from the back, from the front, from the sides, and if done in the right patient, can give great results.
Now, another thing I heard about, which it just really blew my mind, is these synthetic discs where surgeons can actually go in there, remove the deteriorated disc, slide in this synthetic disc, which is probably even better than the regular disc that it's replacing because of the content and cushion and everything else it's made of. Now, what exactly is involved with that?
So there are very small percentage, but there are patients who can be a great candidate for a disc replacement surgery. In these patients usually present with low back pain, and they have, when we do an investigation, find a very degenerated dark disc, usually a single level disc. And for this, we have to go from the front, from the belly, we go in, clean out the disc, and put this artificial disc. What's the advantage of an artificial disc? Well, we are able to keep the movement of the disc level intact, because blocking a movement causes increased stresses on the segments above and below, causing them to degenerate. So keeping this movement intact, we are not biomechanically harming the spine. So we are not doing fusion, these are non-fusion surgeries, and patients do great with it.
And the synthetic material gets along fine with the body, where there's no major rejection and all these other problems that you hear with these other things, because it is the spinal column, right?
Yes, good question. So again, this is very unlikely that the patient will have any rejection on these. These implants are very biocompatible. They have been tested, have been researched on, and have been used in a number of patients before you even get an FDA approval. So these things are researched very well on it.
And just before we get ready to wrap up here, I had a couple other questions for you as far as the surgeries are concerned. Now, someone goes in for a back repair, lumbarectomy. I could go on and on about some of the ones. Now, a lot of these people think that because they had back surgery, I'm going to be out of it for 2 or 3 months. I'm going to be, a half a year and everything. That's no longer the case with these surgeries, is it?
We try that our patients get out of bed the same day or the next day, so that they are mobile. Definitely the fusion surgeries are bigger surgeries. They are
Right.
a little more painful. We control pain for the patient. We keep them in the hospital for a few days
Right.
and then send them out. But these patients are mobile right from the day one, and we keep them active so that they can get back to their normal life as soon as possible.
So compared to, let's just say, even 6 or 7 years ago, the turnaround time with these spinal surgeries has decreased majorly compared to where they used to be 5 or 6 years ago. So people who maybe need these surgeries, they should not have to worry about recovery time.
I think we have come a long distance over the, I would say, last 2 decades with all the improvements in the surgeries, in the way we do it, in the approach we do it, and how we treat them even after the surgery. We have a team which works with the patient, the physical therapist, the hospital, and everything to keep them mobile, to make them out of bed as soon as possible, to keep the complications down, and to keep their quality of life high.
Well, we're basically out of time here, but if you stay tuned for part 2, you'll catch part 2 on this program later on this week, and we'll have more. This time we'll be talking about the neck. Until next time, I'm Larry Mike Arinda. I'll see you right here on this channel.
I'm Vedant Vaksha. I work with Complete Orthopedics. We have offices in Stony Brook, in Little Neck, and in Babylon, and I can be reached through our website, cortho.org, or through our phone number, 631-981-2663.